Here again with Employer Direct Care, and we're very fortunate to have Dr. Matthew French today as we celebrate the American Heart Association National Heart Month and Go Red for Women. So welcome, Dr. French. Thank you for coming today.
Thanks, Aaron. I'm looking forward to this talk, and it's very timely for a variety of reasons that we will get into. But being that this is National Heart Awareness Month, it seems, although we've all heard about as much as you can possibly hear about the pandemic over the last month, we've maybe been neglecting some other preventative and sounds that our body's been trying to tell us over the last year.
Yeah, I get a lot of questions from our patients here. Sometimes it's a struggle to get some of our points across about health, heart healthy topics. So I'm really excited to have someone who specializes in it to kind of back up what we're saying here and what they've heard and really kind of the rationale behind it. So with that, let's figure out how to share our presentation here today. They're used to me not being very tech savvy, so.
That's okay. And while you're doing that, I might just mention that what I do is I'm an interventional cardiologist. So when we get to the very later stages of disease, such as heart attack or heart failure, the horse is already out of the barn. Now we have some good treatments to offer if someone happens to have a heart attack, efficiently opening the artery, and it usually involves placing a stent. But if we can prevent way down the road and rewind time to do some common sense prevention, we can hopefully avoid getting there altogether.
Yeah, that's definitely, I think, all of our goal is we don't want to get to that point and have lots of long-term possible consequences. So let's kind of dive right in here if we can start this. So just kind of some topics we're hopefully going to talk about today. Just kind of what are we talking about with cardiovascular disease? What are some risk factors for getting to that point? A hot topic with a lot of my patient population is energy drinks. They're tired, they're working, having families, and do these really help, or is that a problem for our heart health? And then just what can we do to prevent some of these conditions from occurring? What screening do you recommend? And back to you, Doctor.
Yeah, I definitely would love to jump into that. I don't know if you have a share content button on there.
We were. See how I here?
But it might do the trick. Of course, I know these. I have these slides memorized now.
I know. Well, it said share content a minute ago, but
So while you're working to get that up, the slides, I actually usually ask the same questions over and over again, and have been doing so for 20 years. So I did like what you said earlier in our conversations, that we come at this from being very human. There you go. And we're actually part of the struggle along with the patient, and we're certainly not perfect ourselves. So are you able to go back one slide? I don't know if you can, but this was a what I felt was a neat way to lay things out, as you did, talking about the basic heart diseases, and then talking about what our common risk factors are. A brief discussion about something that is a hot topic right now in terms of over-caffeination and hypertension, and how some of these energy drinks can really cause some harm. And then number 4, what we really like is to get to some prevention. And then, what are the necessary cost-effective screening measures that that we both can talk about. Next slide. Okay, so I bet you see a lot of patients like this in your clinic. I know I do. And as a society, as we age, not only does our metabolism slow down, but the reality of it is that we've gotten pretty far away from nutrition, especially in this last year of the pandemic. It's very easy to maybe watch your Netflix binge show and maybe making a few too many trips to the grocery or to the refrigerator or whatever your telephone can order you to be delivered. And we've become bigger and fatter as a nation. And we'll discuss a little bit about the problems of that and what we can do about it.
Wonderful. So I talk a lot about, obviously weight loss, exercise, nutrition, and you hear these different terms of, if the excess weight is held lower or higher, why is that important and why does it matter? Isn't it just if you have excess weight, that's a problem in general?
Well, it's a good, it would be great if it were, hey, I'm a little fat, but that's not going to hurt me. But we certainly know now that it's a very dangerous metabolic situation that sets you up not only for diabetes, but the longer we live, we can get the different signs of blindness and kidney disease, heart attack, and not even have good feeling in our feet. And there's a whole host of things that obesity ultimately causes. And I think in our next few slides, you and I can tackle that.
Wonderful. This is Baby Yoda in his pandemic quarantine there, but he's super lazy since he had the cape on. So Baby Yoda's been a fan at my house lately.
Yeah, Baby Yoda's been a fan in my house as well. That was a big Christmas gift. And, Baby Yoda is good because Baby Yoda has a lifespan that far exceeds ours, apparently.
Maybe not with that diet.
What's that?
Maybe not with that diet of chips and Coke and sitting around watching TV, like you were saying.
Yeah, I think you're being a little unfair to Baby Yoda, though, because I think he was just eating the, the eggs of the, one of the toad creatures there. So he was fairly organic, at least in the Mandalorian.
Right. We'll give him that.
But he's definitely a snacker. We'll say that.
Let's talk about smoking a little bit. No one ever starts smoking and says, I'd really like to have heart disease, lung disease. They don't pick it up to get addicted to nicotine. They do it for whatever. Their friends are doing it. They think it looks cool. But a lot of times people don't really see the consequences of their smoking. They feel fine, or maybe they have a little bit of a cough, but it's just because I'm a smoker. What does this do to our heart health?
Well, the way I describe it, in short, is that it's, we're all a sum of our habits. And smoking, to me, with regard to heart disease as a cardiologist, is like pouring gasoline on a fire. I mean, it honestly, to me, it is the most powerful risk factor that, can take, can take everything off the table. I mean, I've, seen someone as young as 29 with no other problems have a heart attack from smoking. So, and I think you hit the nail on the head that it's, certainly the carcinogens and different substances in the tobacco that are inhaled that at least quicken the pace of heart disease or blockages. But the addictive substance is nicotine. And, I think it's far more addictive than alcohol. Obviously we don't want to substitute one for another, but it's the easiest way to avoid it is to not start it.
Sure.
But I don't know what you tell your patients, but I usually say that, the best time to quit would have been 20 years ago, but the second best time is now.
Absolutely.
What do you usually do?
Absolutely. I mean, I have a pretty similar statement to it that, it's never too late to quit, to start getting some of the health benefits and decrease some of the risks. And it's hard for people to really understand that. It's hard to quit. I get a lot of patients that say, well, I've tried, the patches, the gum, Chantix, other medicines. And, we really have a really big discussion about it's so much more than, a magic pill. It's being in the right frame of mind. It's having the right resources, the right support. And I think that's where a lot of my personal patients get a little bit hung up is, they don't have the time a lot of times for the classes and those things. So it's encouraging to see a lot more online resources. And as people become, more online focused than anything else, that there are resources out there to help them get through it. But I totally agree that, I would love every time I said, hey, this is really affecting your health, that they would just stop. But we know that's not always the case. So my kids thought this one was pretty great. One of the things, and I think maybe even especially, maybe as a woman, I don't know, it really does age us. And I think this is one of the physical consequences of, some of our bad choices in a habit. I really don't think this woman was 48, but I think it drives home the point.
Yeah, it definitely does, and I kind of liked what you said earlier. I think doctors and whether you're a nurse practitioner or physician assistant or we have failed woefully because of the 10 things that we want to get accomplished in a 15-minute office visit. Simply saying you need to stop smoking is not going to do the job. And really a referral to, we do have at Wilson Health a counselor whose favorite part is smoking cessation and knows all of the medicines and all of the available literature to really achieve the best long-term success rate of quitting. And it's like a lot of addictions that people think there's no way they can do it, but once they get through it, they're like, I wish I never picked up a cigarette ever. And so it does take a team approach there. I do agree.
I agree as well. And, I think just helping our patients find those resources and identify the importance of those is really important during that time to try to find those, like you said, put those 10 things into a visit or 10 things or more that you're trying to get your point across. But this is a very big risk factor to multiple aspects of their health.
Mm-hmm.
So people say, well, what's the benefit? I've already done it. There's not going to be anything good that comes from it. But I found this little graphic kind of helpful. Just, what happens some things are very quick, some are years down the road that they can see the benefits from. And, from our heart standpoint, even a lung standpoint, what has been your experience and what do you kind of tell your patients?
I love that slide because, yeah, whereas I don't want to say you can wait longer to quit because your lungs may, turn back to normal in 10 years. But the fact of the matter is that their prognosis improves greatly from, whether they're dealing with lung disease or heart disease or vascular disease. And, so I think this is an optimistic slide, which is true. That, that after 10 years, you really can improve your breathing and your lungs can heal.
Yeah. My final slide on this one was, can you explain to our viewers what's going on here? So we saw kind of a picture of the outward effects of smoking, but what all is going on here?
Well, it's kind of a Rorschach test. And if you look at the one on the right, it looks like two turtles looking at each other. And no, it's obviously, you can tell the fact that all of the hundreds of carcinogens and toxins that are in tobacco, although it seems like it is as we know a plant, but it's causing this type of damage to the lungs and also accelerating the pace of hardening of the arteries. So I'm sure you see and I see when people start getting past the age of 40, they might have lung disease, they might have heart disease, bad heart, bad lungs, and we want to push our lungs more towards that picture on the left. Don't you think?
Absolutely. I just found this every time I see this slide, and obviously I've seen this for years and years of my career, but just how large the heart gets, the displacement of the lung tissue, and just kind of how crowded. I mean, even if not just the color, but I think that really speaks a lot there, just knowing what happens going on inside of us if you do decide to smoke. So hopefully we can avoid that in our patients or start to at least stop that process for them.
Absolutely.
So family history. Sometimes I run into patients that like, oh, my family's all fine. But, after you start talking, get to know them, you realize, well, they do have heart disease, high blood pressure. But they say, well, I'm healthy. That didn't affect me. What does family history play into our cardiovascular health?
Well, I think looking at this, over the last few decades, if someone has in your family has a heart attack less than 50 years of age, that will qualify you for having a family history of premature coronary artery disease. And I think that's important because there are some genetic predeterminants of coronary artery disease, and we don't know all of them. We know one big one is, that your fractionated lipid profile is most likely more determined by genetics than it may be your diet.
Wow.
So that to me, is what I really look for with regard to family history.
Sure.
The age of the first introduction to heart disease or heart attack. How about yourself?
Absolutely. I also find when you talk a little bit about the family history that I try to get an idea of what the family unit looks like for overall health behaviors. whether, you know, the rest of the family is very active and the patient in front of me maybe is not adapted or adopted that lifestyle. So I think we can get a lot of good information from knowing what activities the family unit or past generations, you know, were involved in, and just kind of that family diet. Because I know I like to serve my family, you know, meals that have been passed down, and, you know, we eat a lot of butter noodles and cabbage, and other than the cabbage, there's not much good in there. So I think that looking into the family history from a social aspect too can offer some insight into their overall health.
Yeah, and you know, just by bringing that up, you also you know, kind of jarred my memory. Multiple times we're concentrating on the patient that has a heart attack and trying to stop smoking, but maybe their spouse still smokes.
Yeah,
And
absolutely. Right.
you know, that's very, very difficult in that setting to try to you know, to get them both to quit at the same time.
Great point. Well, and you jarred my memory as well. Can we just add a little bit of, you know, vaping? I mean, that's happening at such an earlier age that, you know, I hear about it in my kids' school that are all, you know, teenagers, junior high age, and even my adult patients say, "Oh, well, I stopped smoking." I'm like, "Oh, that's so great." And then I find out they're vaping. Do we know fully what those risks are to our heart?
No, we don't. And, you know, obviously, um, you know, that prior to the pandemic went through a very um, sort of fine view that these companies might be marketing this seemingly benign electronic cigarette to teens, but it's a delivery system for nicotine, and there it's certainly, let alone the fact that it does have its own toxicities. You know, you're starting at an early age with a nicotine addiction. That being said, vaping, you know, now certainly isn't remotely mainstream recommended for stopping smoking. And, you know, I will say, though, that with regard to nicotine withdrawal, certainly the patch and the gum are, you know, wonderful aids in stopping smoking. And it just, you know, it raises a tough situation when you know, when you get teenagers exposed to this, and you're actually trying to, you know, prevent, you know, helping people stop smoking. And you know, that's where the catch-22 lies with regard to vaping. So point well taken.
Thank you. So we've talked a lot about prevention, what kind of leads up to this. So what actually is going on? I mean, you know, I tell people all the time, high blood pressure is kind of that silent killer, you know, that used to hear all the time, because they feel fine and they don't understand why they need to take medicines when their blood pressure is 180 over 110. You know, I feel fine. You know, and some people don't even get a headache or anything. So what really is going on, and why is this such an important issue?
Well, this is my favorite slide, actually, as an interventional cardiologist, or just a cardiologist, or just someone that can really define the benefits of every medicine that we prescribe based on this one slide. And you know, if you start on the left, you know, the first thing you sort of realize is that the bad cholesterol, or LDL, low density lipoprotein, gets oxidized by free radicals. And people would say, well, what are free radicals? Well, free radicals can be anything from, you know, just radiation to, you know, to from the sun, or to various foods we eat. And, you know, we have tried many trials that have antioxidants like vitamin C, or you know, vitamin E, but they don't really haven't really shown much benefit in terms of dealing with the free radical problem. The free radical problem also is something you hear with cancer, that it might alter our DNA in some fashion, creating cancer. But it's that oxidized LDL that then your immune system comes down, and you see these monocytes, tries to engulf these oxidized LDL particles, becoming foam cells and creating a cholesterol plaque. And the action is really on the wall of the artery. So the bad cholesterol that is oxidized gets absorbed, and lo and behold, we get a plaque. You see CRP there, which stands for C-reactive protein, which brings up an interesting point that I don't think a lot of people understand, that atherosclerosis, or hardening of the arteries or blockages, is an inflammatory process. So that also does kind of involve some genetic predeterminants. And I describe it to my patients. I say, well, you see a 16-year-old kid that has no acne, and you see a 16-year-old kid that has a lot of acne. Well, there's a lot more inflammation on the face. And a lot of people refer to coronary artery disease as acne of the coronary artery. And, that is why we recommend that statin therapy, because it actually is an anti-inflammatory, but it does also reduce the levels of that bad cholesterol. And then finally, if there's really one of three things that can happen. If the cholesterol plaque grows in this pipe and takes up enough surface area, just with simple exercise, you can get chest pain that's relieved with rest. But if you cut yourself on the outside, you want your body to clot, so you stop bleeding, but it really doesn't know the difference. And if you rupture a plaque on the inside of your heart, the blood clot itself will close the artery off and cause a heart attack. And so, just from this one slide alone, you can see the rationale for using statin medications, for using baby aspirin to try to, tilt the ongoing battle between your endogenous thrombolytic system, which is kind of keeps the blood from clotting, versus the clotting system. Tries to tilt that in favor of blood flow and not clotting. And the stress forces on the actual plaque tend to be hypertension as well, which shear force can cause that plaque to rupture. So treating hypertension, treating cholesterol, and we'll get in a little bit more to why diabetes is a problem. But I think there's a lot of information in this slide alone.
I agree. I think it's wonderful. Just even if you have no idea what any of those words mean, you can definitely see that that buildup of plaque, that narrowing of the artery. And I tell patients, think about your garden hose, and the water flows out freely, but if you start to if you get mud or dirt or whatever, it's just old and very hard, that causes a lot of problems with the use of that hose. Sometimes you can get the little it'll break and rupture. So I think this really is a great diagram of what's going on inside. Thank you.
Yeah, and it's not just the arteries of the heart. I mean, this is a very similar process that can happen in the brain, and also, I mean, you don't want to run your tires on too high a tire pressure, but people tend to, because they don't have symptoms with hypertension, really be resistant sometimes to therapy. And it really honestly is probably one of the most important things we can do, certainly to prevent stroke, but also to reduce heart attack.
Absolutely. I tell people if you injured your ankle, you would use crutches to help get over that, or a bandage. And this is the same thing. Even though you felt okay, afterwards, you may still need some treatment, some ibuprofen, an ACE wrap or something. But just because you can't feel it doesn't mean it's not doing a lot of damage. So
that's right.
So what is this cardiac CT scanning, and what is it that we're all looking at here, and what should we take away from this?
So, this is a very important slide. For years and years and years in cardiology, we used to put patients on treadmills and get their heart rate racing to see if they had any changes in the EKG, symptoms of chest pain, and we'd even combine it with some sort of imaging study, such as nuclear cardiology or echocardiography after a treadmill. But in reality, those tests have fallen out of favor because, number one, they're expensive. Number two, they really only will pick up 80 to 90% blockage. And if a patient doesn't have a symptom, they're actually contraindicated if a patient doesn't have a symptom, chest pain or shortness of breath. But this is a cardiac CT scan, which, on the average day costs $99. There might be some discounts in February for women because this is Women and Heart Disease Month. But you can see on the image on the right that's circled there, and I always like when we have things circled as we're reading studies. But there's a lot of calcium, and calcium is correlated with coronary artery disease. Now and it's also correlated with events, the heart events, such as myocardial infarction, which is heart attack, stroke, and also death. So, if we get a heart scan and we see that it's elevated, the horse is still in the barn, and we can sometimes even reverse the hardening of the arteries with aggressive statin therapy. But there are many times you'll have a heart scan like this, and a stress test is going to miss it if it's not 90% or greater. But this is also powerful motivation to stop smoking and control some of those risk factors right from the get-go.
Who do you recommend gets the cardiac CT? You've mentioned the stress test is only if you're really symptomatic, and even then it might not be the standard of care at this point. So what patients should I be referring for this?
So, I think, whereas I realize, it's kind of a rhetorical question, but, we want to have a somewhat of a mild to moderate probability of disease when we do this. So, in other words, we wouldn't want to send a 25-year-old female that doesn't have any risk factors for this, nor would we send someone that already has had bypass or stenting, or that's in their 70s or 80s. But if someone's in their 40s and they maybe are a smoker, or they have high cholesterol and one or two risk factors that makes them an intermediate probability for having this, with an erring on the side of wanting to find more than not, it'd be okay to have a few normals, like on the left. I would say, really 40 and onward with one or two cardiovascular risk factors.
Okay, wonderful. Thank you very much. So now the all-important that every patient gets. A lot of our wellness programs make people get a cholesterol panel, a lipid panel every year. So this is something that I think I talk about daily to almost every patient, whether they got labs, they're due for labs, or just how to make sure they're on the right path. So earlier in the talk, you mentioned, the statins for lowering the cholesterol here, and what are some of your recommendations, and, what are you doing with your patients, or even at the end, what if they can't tolerate a statin? I get that a lot. Oh, I don't want to take it. I've heard problems. I can't tolerate it. What can we do for those folks?
Yeah, I think we all get that question often. So I look at it a few different ways. I mean, aches and pains and cramps are very prevalent as we get over, 45. I mean, daily chronic pain. The studies really show that statin-induced myopathy or aching is about 1 to 5%. So 95% of people should do just fine. But, to me, and we do have different ways of, like, I usually, let's say I try atorvastatin or, pravastatin or, a Mevacor. Crestor tends to be a little metabolized a little bit differently, and I understand this is a little bit overly technical for this talk, but it is metabolized a little bit differently. So a lot of patients that can't tolerate one of the others can tolerate Crestor for some reason. We also have, injectables that are expensive and a little bit difficult to pre-approve, but you only have to do it twice a month. And we even have a newer drug that works at an enzyme before the enzyme that statins work at, the HMG-CoA reductase, that doesn't cause cramping. It's called Nexletol, and not a lot of people know about it. It's indicated for add-on therapy if you don't meet goal, and that's really what we could, one of the things that we probably should drive home is, that I think everyone needs to know their numbers. They need to know what their blood pressure is. They need to know what their hemoglobin A1C, which is a measure of blood sugar, is. They need to know what their weight is. They need to know that if they have this cholesterol profile and they don't have coronary artery disease, their goal for bad cholesterol needs to be less than 100. It's 185 here. If they have coronary artery disease, which was diagnosed by the previous slide, so we can diagnose coronary artery disease from a heart scan, then this patient is going to need to have that LDL 70 or below. And we know also that the small, dense particle cholesterols, which we don't check in every fractionated study, but this Lp(a) is a very high risk of having problems down the road with coronary artery disease and heart attack. So, it's as we get more information about an individual patient, there's more that we might be able to to do with regard to convincing the patient to not only use diet and exercise, but really go on high dose statin therapy and follow this cholesterol profile and forward, so that we make sure that we target our therapy appropriately. So many people, and I feel for primary care physicians in this day and age. They have to do cancer screening. They have a lot of paperwork that gets handed to them, disability papers, for example, and they, let alone coughs and colds, routine blood pressure control, and orthopedics. They have everything. They're captain of the ship. So I do really think that it does fall on our shoulders to make sure that not only we treat this to the appropriate numbers, but we follow up and make sure those numbers are achieved, and then have a patient really kind of buy into that success and knowing what your numbers are.
Wonderful. It is. I think I'm starting to see a little bit more of a trend in some of the wellness things and initiatives within the companies here. So they're getting these numbers. We actually started doing point of care testing. So they get their lipid panel, they come in, get their blood drawn, their A1C, and I go over it with them on that same visit. And it's been really great to not have to, call the patient. We're face to face. So I think they're getting a little bit more information, and I think that's really hopefully the route that we're going with some other testing, because it's different when you see it and we're sitting there talking versus me calling you over the phone and going, hey, it's fine, or it's not fine, and maybe they're busy. So I think that's been pretty positive for us here at EDC.
I agree. I think it's night and day. We're being asked to see more and more patients, and when we can get a patient a result in 2 minutes with a very tiny blood little poke of the forearm or the thumb or something of that nature, or the side of the finger, it's much better to have that talk and have them walk out with those numbers, knowing exactly where they are. And it's great, for things not getting lost in the shuffle. And unfortunately, things still get lost in the shuffle.
Yes, they do. Yes, they do. So I think that's exciting. That was an exciting advancement here at our clinic to get those things, and that's the first thing they get done. So as we're talking, I can go over those with them. So I enjoy that.
I miss it. And, even in the cardiology literature now, it's so important that our governing bodies will not even make patients fast if they can, start treatment and get a cholesterol profile in the office. And it's that's hot off the presses. I mean, I'd never really even heard that before, but it's becoming more routine to see where someone is as they walk into your office. It makes it a lot easier on the patient. They can't get their morning cup of coffee and their MPO with nothing to eat after midnight. They tend to curse the doctor and nurse practitioner a lot.
That is true, but that's very interesting, and I look forward to hearing more about that and how we can use that to help our patients.
Mm-hmm.
So metabolic syndrome, I've talked about it with my patients. I think people, for the most part, have at least heard the term. And this kind of ties together, I think, a lot of what we were talking about. And this just isn't, necessarily, hey, you might have a heart attack, but you're talking about high blood pressure, high triglycerides, which are part of the cholesterol, low good cholesterol, and that HDL. So this metabolic syndrome, what does that mean to you as a cardiologist?
Well, I think you summed it up nicely. I think it just, goes back to what we said at the beginning, that, being a little fat is not, that's not just the problem, that it's a metabolic problem. And we all know that, type 1 diabetics, their pancreas doesn't make insulin, but, there is a limit over time where if you become obese and your insulin, the tissues, can't, pull the blood sugar into the cells, then we end up with a situation where we have high blood sugar that precipitates out in the eyes and in the, also the heart arteries and the kidneys and the nerves in the legs, and we see this high blood pressure, and that it is truly a syndrome that is putting you on a path for what we would call end organ damage, or a heart attack, or problems with your kidneys or your eyes. So that's to me, a beautiful slide in that regard.
I like it well, and I think I'm going to pull this off that you had put on here and use it as a good visual for our patients here. Just, we're not piecing and parting you out. This is a systemic problem. It's, something more going on, and we need to kind of attack all these different areas to be as healthy as we can. So I think this is an excellent slide, and I appreciate that.
Mm-hmm.
All right, this is a hot topic with some of our companies here, our patients. I have a lot of young 20, 30-year-old guys that, are out working all day. They go home, they're up late, and then they're tired. So they're coming and drinking all these energy drinks, and they say, I have to have them. I need energy. And they're not bad for me, so what is the consequence to this? We know it has a lot of caffeine, and caffeine can, elevate blood pressure some, but is there truly harm, or is it not as bad as, I'm making them out to be to my patients?
No, there's, it's akin to vaping, to be honest with you. And it again, it starts, I had my 10-year-old ask me for some Monster energy drink the other day, and the caffeine of this, 80 milligrams of caffeine, this is something that you almost would have to regulate with the FDA, this large amount of caffeine.
That's a lot.
It obviously will make the heart go faster. It will raise. You'll end up having a crash, a little later on. And in this case, you're also exposing yourself to, multiple teaspoons of sugar that that you don't need. And I've seen, and I'm sure you've seen, we in this society, will push ourselves and push ourselves and push ourselves. And, whether you're cramming for a test, or you're, trying to see the last 5 patients, or you're trying to meet your boss's deadline, or
Well, it looks like
a problem.
We lost you there for a second.
Oh, did you lose me?
We did.
Okay. Am I back?
You're back. Let's pull that back up here. There we go.
Okay.
All right. So I'm glad to have somebody else back me up here that says these are not an ideal drink. They are not a substitute for good nutrition, good rest. So I really appreciate that, because I think sometimes they just look at me and roll their eyes, and that's okay. I can handle that. Except I lost your little picture here. So one thing I want to talk about is prevention. So, we can sit here and say, we talked a lot about smoking, exercise. What is the recommendation for exercise? I have people say, oh, it's as long as I get up and move during the day. But I really want to stress to our folks that, we can prevent these things, and that's ideal to not have long-term health problems, as well as decrease their healthcare costs. I mean, healthcare is not cheap. We all know that. So how can we make things better for these patients? Oops.
Well, again, I mean, you kind of put this in my mind, Aaron, that I think it takes a lot of pressure as off. Can you hear me still?
Yeah, we're good.
I think it takes a lot of pressure off the physician to be, all in this together, or in a way, because it's not easy. I know the hours that you keep, and having a family, and it's the first thing that you think you would want to that might get cut is your exercise regimen. And a lot of us have been under this quarantine, and not everybody can afford a Peloton bike or something like that. But what we're looking for is very simple, really. And I don't, I'll tell my patients, anything to keep them motivated. If it's 10,000 steps a day, if it's 30 minutes of walking the dog in the evening, I'll take it. We know you can break exercise up into smaller portions and add them up, and you get the same effect. And really, diet, I sum that up pretty quickly. You can, I'll say, I'll go through the day. I'll say, you could have oatmeal in the morning. You could throw some raisins in it, or you could, maybe have an apple, and it has a lot of fiber, and you'd be surprised that you won't be hungry until lunch. And then at lunch, maybe you do a half a sandwich and a half a bowl of soup or something like that. And at dinner, we really want to stay away from places that are trying to sell food, because they don't have your best interest at heart. So this is a chain-driven nation now. We have Applebee's, we have McDonald's, and all the rest of the fast food, and Kentucky Fried Chicken. It almost seems normal, like that's normal for you to eat that. But the reality is that is what is contributing to ultimately a shorter life. And we know that the youngest generation is predicted not to outlive the generation preceding it. And a lot of this has to do with this overeating. If you're a couple, maybe you split an entree, and when you're cooking at home, you just make common sense decisions, like we've all done when we feed our kids. Put some green on the plate, and try to eat fish once or twice a week.
Not fried fish.
That's right. I mean, if you're at the the church fish fry, you can have a a cheat night. But and we're not saying don't take your grandkids to get an ice cream bar after a baseball game. But these habits, even if we can get a marginal percentage increase over time in the performance and attention to these things, you're gonna see a big difference, because this is a daily habit that ultimately becomes a problem. And childhood obesity, as almost guarantees that you're going to be obese as an adult. And I'm struggling too. I'm technically obese. I look at every day. I look at that formula. I'm like, there's no way. But we're all in the same boat.
We are. I think that's so true, and I try to be very open and honest with my patients here. And I struggle as well. I grew up in the clean plate club, where if you didn't eat everything off your plate, you got in trouble. And yeah, I'm guilty. Work 10 hours, go through a drive-through, and I'm only going to do it today. I'm only going to do it today. Well, it's always today. So those are some things I'm working on at my, for myself. So I think as providers, it's important to know, for our patients to know, we're not perfect, and they can look and see that I'm not, but we're all trying to do our best, and, all work together to make their health the best. So.
Well, I think You know, we kind of did a deep dive into it today, and you know, like many things, the practice of the religion of prevention is harder than just to read it. But you know, let's you know, take it one day at a time and keep trying.
Yeah, I agree. There you are. Well, Dr. French, if last takeaway for this, if we can impart one piece of wisdom upon the patients here at EDC, what would that be for you?
So my one piece of wisdom would be that all of us have gone through an insurance physical before, and you know, I have patients that have a variety of conspiracy theories, and I'm sure you do too.
Yep.
But you know, the insurance companies that probably make more money than you know, really maybe any other industry. It's a toss-up, but they know that if you have high blood pressure and high cholesterol and you smoke, that your risk of having a heart attack or a stroke with a prolonged, very expensive, very debilitating, you know, hospitalization and possible rehab and taking you out of the workforce. They know that they have the numbers on all of these, and so you know, to me, why would an insurance company, if you can't believe you know, your healthcare provider, and you think the pharmaceutical companies are in it to make money, which they are in some ways, but we have plenty of generics, and then you know, think about it. From the health insurance company perspective. And, you know, our job is really to coach and, you know, approach this in a humble fashion, but, you know, we see both ends of the spectrum, and, you know, really want to help our patients stay towards the left end of that spectrum instead of the right end. But I think you know, you and I are kind of you know, we're kind of warriors in the same battle that a lot of people are fighting right now.
I agree. Well, Dr. Matthew French, I greatly appreciate your time today, as do all the employees here that use EDC. I just want to thank you for your time, and if you have any questions, please feel free to reach out to me or Dr. French. He can be found at Wilson Health Cardiology up in Sydney, and please just give us a holler and we'll help connect you guys together. Thank you very much, Dr. French.
Thanks, Aaron, and look forward to talking to you soon here. All right.